Well, good afternoon, everyone. I see everyone is joining little by little. And so for the sake of time, it's 12 o'clock and we're gonna go ahead and get started. Thank you for joining on time. Again, good afternoon, everyone. Thank you for joining us today for the second week of our CRCR prep series. This week, we will be covering sections 1.6 through 1.10. And before we get started, I'd like to review a few housekeeping rules. Please mute your computers and turn off your cameras until opened for questions at the end. Use your chat throughout the session to ask any questions you may have. I will try to keep up with the chat, but I also have a few helpers that will be helping me throughout the session. And so I think every few slides we'll do a chat check and see if there's any questions we need to cover. All the sessions are being recorded and will be placed on the Florida FHMA YouTube channel. So you'll be able to access that at a later time. And lastly, please know that we will only be covering key concepts here, thus you must still take the course on your own. We highly recommend that you do it before joining us for a session or right after we finish a session, I would say during the next few days after that, so that everything is still fresh in your minds. And so with that, let me formally introduce myself. My name is Natasha Caballero, and during my day job, I am the Director of Patient Access for Sylvester Comprehensive Cancer Center, which is part of the University of Miami Health System. I have over 16 years of healthcare field experience, and I have had oversight of different areas such as outpatient clinics, admitting, scheduling center, benefit advisor and financial counseling team, on-site insurance verification, and then most recently, of course, our COVID-19 testing and vaccine sites. I graduated from Florida International University with an MBA and have learned a Lean Six Sigma Green Belt from the University of Miami and FIU. I've also been awarded the HFMA's CHFP and CRCR certification, as well as completed the Patient Access Essential course. And in addition, and the reason why I'm here, I am part of the FHMA certification and education and South Florida Education Committee. So with that, we're gonna go ahead and get started. And so section 1.6 talks about Medicare compliance and regulations. And so bear with us as this is very content heavy, and I'm sure there will be questions throughout. And so with Medicare compliance and regulations, that helps us identify Medicare compliance issues specific to patient-centric revenue cycle and identify coding issues specific to the patient revenue cycle again. And so you will be seeing terms such as MS-DRG window, which it usually defines when CMS considers outpatient services to be an extension of inpatient admissions. We also have the 2-night midnight rule, and that usually states that inpatient admission and payment are appropriate when treating the patient to require a stay that crosses 2 midnights and admits the patient based on expectation. We're also going to be seeing the correct coding initiative, modifiers, and Medicare secondary payer, which I'm sure everyone is familiar with that term or at least has heard of it. Any questions before we move on? Let me check a quick chat. No questions yet. All right, so as far as compliance programs, these identify key risk areas that can lead to potential fraud and abuse for hospitals and providers, and they include upcoding of MS-DRG assignments, inaccurate or incorrect coding, bundling and unbundling of services, duplicate billing, billing for medically unnecessary services, waiving of deductibles to entice businesses, insufficient documentation, and these are just some of the key risk areas. A comprehensive plan along the lines suggested by the OIG, the Office of the Inspector General, indicates that our organization is serious about being compliant with regulations and may serve to keep the federal government from dictating a plan for it. It will also insulate the hospital from violations of false claims, which are fraud and abuse claims usually in those regulations. And so in continuation with our compliance program elements, we're talking about self-reporting of adverse administrative events, a corporate culture that encourages the constructive identification of potential or actual violations, full support by the entire organization. So everybody really needs to be on board. Oversight of personnel by high-level personnel. So you have to have your chain of command, if you may. And you also need to have written policies and procedures that give you that sort of check and balance, including an employee code of ethics. And the purpose of this compliant programs is to create a program that is transparent, clearly articulated, and emphasized to all employee levels as seriously held personal and organizational responsibilities, and one that relies on full communication inside and outside the organization. And so to continue on with our compliance program elements, you need to have regular comprehensive training. You need to have those hotlines or other means of receiving anonymous communications about compliance issues. So sort of those, whistleblowing avenues, mechanisms for monitoring compliance, including independent evaluations, and communicating standards and procedures internally. And so the Office of the Inspector General, which you saw that term before, the OIG work plan, focuses on annual compliance issues and addresses the Centers for Medicare and Medicaid Services, or CMS, regulations. It publishes the annual work of compliant issues and objectives, and it will focus on it throughout the following year. Providers who are found to be in violation of CMS regulations are subject to corporate integrity agreements. In the early to mid 1990s, the government investigated and subsequently settled with several high-level healthcare organizations in the United States for alleged healthcare fraud and abuse. And the government secured substantial fines and penalties from these organizations and entered into forced compliance program settlement agreements. These forced compliance programs included not only fines and penalties, but also substantial requirements for auditing, monitoring, education, and ongoing reporting to the federal government. And so next on our compliance program, what we do with the code of conduct. And so specific Medicare compliance issues, and this is one of the terms we covered in our first slide, Medicare as a secondary payer. And so Medicare from the beginning has required payers in certain defined situations to pay the entire claim. And MSP requirements are clearly defined as well. So I'm sure, and you've all heard of MSP, and if not, this is a requirement that Medicare has for all healthcare providers. And so anybody that says they have Medicare, patients are required to answer a set of questions to determine whether Medicare is the primary or the secondary payer. Medicare never wants to be primary payer if there's someone else that can take the bill, of course. And so that is what this questionnaire helps you with in determining who pays for the claim and who's primary or secondary, etc. And so again, from the beginning of the Medicare program, certain payers have always been liable for payment of claims. And more recently, with the enactment of the Medicare Part C or the Medicare Advantage plan option, this principle has been expanded to include work-related injuries and accidents, such as workmen's compensation claims, Black Lung program and services, Veteran Affairs services, patient enrollment in Medicare Advantage plan, federal grant programs, and public health and service programs. In these cases, Medicare does not make a secondary payment. The amounts paid by the primary payers are considered payment in full. And in recent years, the OIG has been reviewing these claims to ensure compliance with the MSP rules. And so some of these MSP situations include working age, accident or other liability, disability, and end-stage renal disease, or ESRD. And we're gonna cover these a little bit more in detail. And so working age means that the patient age 65 or more or spouse is employed and the patient has group health coverage through that employer. And so this group health insurance, or the GHP as they call it, is provided by an employer that has 20 or more employees. If the if the employer has less than 20 employees, the GHP does not qualify as a primary payer and Medicare is billed as primary. The patient is not required to accept the employer's insurance coverage. In that case, Medicare would be primary, and the employer is prohibited from offering supplemental policy in place of the standard group health benefits offered to other employees. Next, the accident or other liability. When the patient needs medical care as a result of an accident, the liability insurance company may be responsible for payment. Automobile accidents as well as premise accidents are included in this MSP category. Healthcare providers are required to obtain the billing information for the liability carrier. Liability is prime only if the accident did not occur on a patient's own property and if the patient states there is a liability. Required coding on the UB04 or UB10 actually includes the occurrence code and the date of the accident. If no medical payment or other third-party coverage exists, occurrence code 05 and the date of the accident or injury must be provided. The next situation on disability, the patient is eligible for Medicare due to a disability and is under the age of 65 and has group health insurance coverage through a large group health plan. A large group health plan is a group health insurance plan provided by an employee that has 100 or more employees. And so again, in these situations, the patient is under the age of 65, the patient or the spouse has current employment through the employer. If the employer has less than 100 employees, the group health plan does not qualify as the primary payer and Medicare will be billed as primary. And then on the next situation, the end-stage renal disease. And so here, the patient has permanent kidney failure, and that's key with this specific situation, and is covered by a GHP and has Medicare, and has not completed the 30-month coordination period. So for example, after the completion of the 30-month coordination period, Medicare becomes the primary payer unless another MSP condition exists. So the insurance must be a qualifying GHP and must still be in the 30-month coordination period. And lastly, the DRG window. Under Medicare rules, certain outpatient providers certain outpatient services provided by a hospital or entities owned or controlled by hospitals must be billed as part of an inpatient stay. These include all diagnostic tests provided to a Medicare beneficiary by a hospital on the date of the beneficiary's inpatient admission or during a 3 calendar days immediately preceding the date of admission, unless there is no Part A coverage. Outpatient services that are not diagnostic provided to a Medicare beneficiary by a hospital on the date of inpatient admission or during the 3 days immediately preceding the date of admission. And other names for this policy include DRG window, 3-day window, 72-hour rule, 1-day window, or a 24-hour rule. Hospitals may not bill services provided within this window under Medicare Part B if the patient has Part A coverage. And so this DRG window, again, known mostly as the 3-day rule, just some things to keep in mind. It's not a diagnostic outpatient services, diagnostic services provided, and it's defining 3 days. So any non-diagnostic outpatient service is considered related to the admission if it uses the same ICD diagnosis code as the principal diagnosis from the hospital admission. All diagnostic services and related charges provided within the window are considered to be related. These include radiology, cardiology, clinical laboratory, EEG, pulmonary function, and audiology tests. Related charges include anesthesiology and drugs used to provide radiology and other diagnostic services. Services are considered to fall within the window if they are dated within 3 days before the date of admission or on the date of admission. For example, if their admission is on a Wednesday, any services provided on Sunday, Monday, and Tuesday before the time of admission on Wednesday are within the billing period. Ambulance, maintenance, renal dialysis, and Part A services provided by a nursing home are not considered related. 1-day window applies to diagnostic services and non-physician outpatient services. And so all these diagnostic and non-physician outpatient services fall within the window if they are provided on the day before or the day of an inpatient admission. For example, any services provided anytime on a Monday is considered part of the inpatient DRG for any admission that takes place before midnight on Tuesday. Next, medical necessity screening and ABNs. The Medicare program pays only for medically necessary services. Therefore, providers are expected to screen outpatient services for compliance with Medicare coverage rules. If an ordered service does not meet the necessary based on the test and diagnostic provided information, the provider is required to issue the appropriate advanced beneficiary notification, or also called ABN. So an ABN must follow the wording provided by CMS to ensure that the text is easily understood, clearly identify the specific tests or services identified as non-payable, provide the information used to determine that Medicare may not pay for the test or service previously identified, be provided to the patient far enough in advance to allow for the beneficiary to make an informed decision, and be understood by the patient or the patient's designee, comply with the use of the form provided by CMS for this process. CCI modifiers and CPT/revenue code issues. In order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, the Centers for Medicare and Medicaid Services developed the Correct Coding Initiative, or CCI. The purpose of this CCI is to ensure that most comprehensive group of codes rather than the component parts are built. The program consists of edits that are implemented within providers' claims processing systems. The CCI edits are incorporated within the outpatient code editor. The edits also check for mutually exclusive code pairs. The unit of service edits determine the maximum allowed of numbers of services for each healthcare common procedure coding systems or HCPCS code. Using a modifier allows a hospital to indicate a specific circumstance that has affected a procedure or service without changing its definition or code. And the appropriate use of modifiers reduces the need for separate procedure listings on a bill by describing the modifying circumstances. So some key points of what we have discussed. The 3-day DRG window rule requires certain outpatient services that are provided within the 3 days of the admission date by hospitals or entities wholly owned or controlled by hospitals to be billed as part of an inpatient stay. The purpose of an ABN is to inform a Medicare beneficiary before he or she receives specified items or services that might be otherwise be paid for that Medicare certainly or probably will not pay for those items or services on a particular occasion. The situations where Medicare acts as a secondary payer includes working age, accident or other liability, disability, or end-stage renal disease. Also, in order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, the CMS developed the Correct Coding Initiative, or CCI. And the purpose of CCI, again, is to ensure that most comprehensive groups of codes rather than the component parts are built. And we're up on our first polling question. In order to promote correct coding, CMS developed what? A, the Correct Coding Initiative. B, the Advanced Beneficiary Notice of Non-Coverage, ABN. C, the Medicare Secondary Payer, MSP, or D, modifiers. Just give you guys few more seconds. Okay, and so the answer is number 1. So in order to promote correct coding, CMS developed the Correct Coding Initiative. So it looks like 95% of you got it right. So congratulations. So let's move on to our section 1.7. And we're going to talk about ethics now. And so ethics define business or organizational ethics. We're going to identify the resources used to guide the application of ethics, identify ethics issues or violations as they pertain to the revenue cycle. And so when we're talking about ethics in healthcare, we need to think about different things, such as a patient's right to refuse treatment, a clinician's professional standards, or even the business or organizational ethics. And so why talk about it? What to talk about? For example, healthcare complexity, resources to review, ethic issue awareness, and interpretation of ethical behavior. So our society is changing at a rapid pace. We have expanding global economies, increasing workplace diversity, expansion of the information highway, increasing technology, unique generational differences, and as a result, defining and applying ethical business practices and principles, it's important to all industries. Healthcare services are important to both individuals and our society, and as a result, healthcare providers and those that work in healthcare industry have additional ethical duties to the patients and communities they serve. And so examples of ethic violations include financial misconduct, overcharging, theft of property, falsifying records to boost reimbursement, miscoding claims, and privacy violations. HIPAA. So patient privacy is an important standard within the healthcare. Most especially a patient's protected health information, or PHI, is addressed in standards for privacy of individually identifiable health information privacy rule within the Healthcare Insurance Portability and Accountability Act of 1996, and that stands for HIPAA. Employees of providers are required to learn and apply proper procedures to ensure protected health information is secure. However, based on an employee's experience and value system, the employee may not believe his or her actions violate the PHI standards. Thus, business ethics can be violated by an employee due to a lack of awareness rather than any malicious intent. So it's very important to incorporate a lot of training when onboarding new employees, and the ongoing training, I would say, on an annual basis at the very least, especially to those employees that have high access to patient records. And so some examples of violations may include using a personal email account with patient information, access EHR for valid reasons, and not reviewing your own record of your family. And that one is one that we see very often with a lot of our new hires. They think they have access to all these records, and even though they've been trained, they often forget. So what is so important to do the training on an ongoing basis. And some key points: business ethics and organizational ethics represent the principles and standards by which organizations operate. Business organizational ethics are relevant to the conduct of individuals within an organization. And so examples, again, of those ethics violations we discussed, there were financial misconduct, overcharging, theft of property, etc. And so other key points to keep in mind: ethical behavior is important, especially in healthcare. Ethical standards are hoped for and expected by staff and management in healthcare. And it is important for staff and management to uphold the business ethics of the provider and act as peer role models. And so we're up on another polling question. What do business and organizational ethics represent? So go ahead and take a moment to read the options and choose the best answer. Okay, and it looks like everyone answered A, which is principles and standards by which organizations operate, and you're all 91% of you were correct. Okay, so we're moving right along to section 1.8, volume to value, and I'm just gonna do a quick chat check. I don't see any questions in the chat, so let's go ahead and move on. And so in this course, we will address the broad provisions by the Affordable Care Act of 2010, or the ACA, CMS proposed alternative delivery and payment models, and standard quality measures. And so an overview of the Affordable Care Act, or also known as the ACA, it was passed and signed into law in 2010, and it was designed to reform the healthcare systems into a system that rewards greater value, improves the quality of care, and increases efficiency in delivery services. And some of the ACA provisions include improve the quality of care, reform the healthcare delivery system, encourage pricing transparency, and modernize financing systems, and also address the issue of waste, fraud, and abuse. And more details to this may be found on the online CRCR course. The Center for Medicare and Medicaid Innovation is charged with the ongoing development of new models for delivery and payment of services. Targeted innovations include quality improvements and/or increases to efficiencies that could be expanded throughout the healthcare system. An accountable care organization, or ACO, is a delivery system of physicians, hospitals, and other healthcare providers who work collaborative to manage and coordinate the care of a patient population. The point of this collaboration is to ensure appropriateness of care, elimination of duplicate services, and prevention of medical errors for a population of patients. And some ACO types include Medicare Shared Savings Program, Pioneer ACO, Investment Model ACO, Comprehensive ESRD Care Model. Okay, so the HVP-BP is a CMS initiative that rewards acute care hospitals with incentive payments based on how closely best clinical practices are followed and how well hospitals enhance patients' experience of care during hospital stays. The HRRP in this CMS is required to reduce payments to hospitals with excessively high rates of avoidable readmissions. Physician Quality Reporting, or PQR, provides financial incentive to physicians for reporting quality data to CMS. And in 2015, incentives were eliminated and Medicare payments were reduced for those physicians who did not satisfactorily report quality data. CMS used learnings from the first BPCI models to launch the bundled payment for care improvement advanced model, BPCI-A, in 2018, and the BPCI Advanced operates under a total cost of care concept in which the total Medicare fee for services, or FFS, spending on all items and services furnished to a beneficiary during the clinical episode, including outlier payments, will be part of the episode expenditures for purposes of the target price and reconciliation. The comprehensive care for joint replacement aims to support better and more efficient care for beneficiaries undergoing the most common inpatient surgeries for Medicare beneficiaries. Hip and knee replacements, for example, are in this category. Medicare's pay for performance initiatives. And so the standardized quality measures are a critical component of CMS initiatives. Quality measures are tools that helps us measure or quantify healthcare processes, outcomes, and patient perceptions, as well as organizational structure and/or systems that are associated with the ability to provide high quality healthcare and or that relate to one or more quality goals for healthcare. And some key points of this section that we just covered: an ACO is a delivery system of physicians, hospital, and other healthcare providers to manage and coordinate the care of a patient population. The ACA was designed to reform the healthcare system into one that rewards greater value, improves the quality of care, and increases efficiency in the delivery of services. CMS has set a target of moving Medicare payments from volume-based to volume-based to value-based payments, and increasing the types of alternative payments models, which include value-based payments. Quality is an integrated part of the changes involved in the volume to value initiatives. And we're up on another polling question. What is the intended outcome of collaborations made through an ACO? Just take a moment to read the options and select the best answer. Okay, and it looks like most of you answered number C, to reform the healthcare system into a system that rewards greater value, improves the quality of care, and increases efficiency in the delivery of services. All right, and we're on our second to last section. We have about 20 minutes left. This section will cover financial overview. And in this section, we're going to identify the basic components of a healthcare provider financial reports, recognize the difference between terms gross accounts receivable or AR and net AR. Also identify the concepts related to establishing reserves for contractual allowances, bad debts, and charity, and determine how they are presented on financial statements. And so the purpose of financial reports is to present information that may be used by others to make determinations regarding the financial status of an organization. Financial reports are governed by a number of regulations, including those defined by the Securities and Exchanges Commission, or SCE, the Financial Accounting Standards Board, or FASB, and Generally Accepted Accounting Principles, or the GAAP. And so some of these financial reports include the income statements, where you would see your revenues, expenses, and profits, your balance sheet, where you would see your assets, liabilities, and equity, and your cash flow statement, where you would see your operation and investment, as well as financing. In accrual accounting, revenue is recorded when it's earned to permit the alignment of revenue with the associated expenses. Healthcare providers generally use the accrual accounting method. Cash is revenue recorded when payment is received, and funds is record-keeping method to manage categories of net assets to ensure compliance with the restrictions on those funds. Gross and net revenue. To accurately report revenue, a provider must be able to calculate the difference between gross revenue and net revenue. So gross revenue is the total charges entered for a patient for the services they received, while new revenue is the estimate of dollar amount of contractual discount and other allowances against gross revenue. To determine net revenue, financial services must estimate the dollar amount of contractual discount and other allowances that will be applied against those revenues. With the implementation of ASC 606 change to the accounting rules governing the calculation of net revenue, revenue cycle may continue to use the terminologies of contractual adjustments, bad debt, and charity, but the finance terminology and methodologies will be changed. These changes are reflected in change of financial statement presentations concerning net revenue. The ASC 606 creates two types of adjustments to incur charges, explicit price concessions and implicit price concession. And so up next, bad debt versus charity care. Bad debt represents a portion of the patient's liability which cannot be collected from the patient. These amounts represent a failure to pay and not an inability to pay on the patient's part. Charity care, on the other hand, represents care provided to a patient who does not have the ability to pay for the services or portion of services they received. And so some key points for this section. Let's keep in mind that in order to report a provider's revenue accurately, it is important to calculate the difference between gross revenue and net revenue. To determine gross revenue, the charges for all services that a patient has received is totaled. And to determine net revenue, financial services estimate the dollar amount of contractual, discount, or other allowances that will be billed against those services, those revenues. And we're up on another polling question. Which of these statements describe the new methodology for NPR? Okay, and it looks like most of you selected net patient service revenue as gross revenue minus any contractual adjustments applicable to the account. Any additional adjustments are not recorded until the account reaches a zero balance. But I believe the right answer is C, which is net patient service revenue is defined as total incurred charges. The explicit price concession, any applicable implicit price concessions as applies to the specific portfolio of the account. So 23% of you were correct. Okay, and we're on our last section for today's session, and that is 1.10, key performance indicators. And I'm sure this is a term you're all very familiar with. And so the purpose of KPIs, as we all call them, is to identify what you want to measure in your organization and things that you want to reach and your goals. They identify components of an account receivable, AR, aging analysis, and identify the calculation used to determine the days of revenue in AR. And we're going to talk about all these things in this session. And so the hospital and system map keys are strategic KPIs that set the standard for patient-centric revenue cycle excellence in the healthcare industry. Developed by industry leaders and led by HFMA, these industry standard metrics represent the revenue KPIs. The keys define the essentials of revenue cycle performance in clear, consistent, and unbiased terms. And so KPIs, or key performance indicators, set standards for accounts receivable to provide a method of measuring the collection and control of accounts receivables. Benchmarking is used to compare key performance indicators in an organization to an agreed upon average or expected standards within the same industry. There are some key benchmarks that should be used to analyze AR within a provider organization. And so these usually include days of revenue in receivables, AR aging analyses, receivables by ascending balance and descending balance, amounts and percentage of receivables over 90 days, discharge not billed, not final billed or DNFB, cost to collect, cash collected as percentage of net revenue, denials as a percentage of net revenue, and credit balances, days outstanding. General KPIs are days of revenue and receivables, also known as AR days. This is measured. This measure is widely used throughout the healthcare profession to measure how fast receivables are collected. Industry standards for AR are available. AR aging analysis. These are aging reports divide the account of receivables into 30, 60, 90, and 120 days, and over categories based on the date of service and discharge. The AR may also be aged from bill date. However, this presentation completely masks the impact of any processing delays that occur between completion of the service and production of the bill. It is important to age from date of service to understand the impact that timely billing or lack of timely billing has on the collection of accounts receivable. And discharge not final billed, this is the portion of the accounts receivable that identifies charges for patients where services are completed, but the healthcare facility has not been able to bill the claim. There are a number of activities that must be completed before submission of a bill, and that can take place. And these include completion of all charging, final medical record coding, and could include insurance verification activities. Cost to collect, because healthcare is not typically a cash upfront business, there are cost to collect for services rendered. This cost is calculated by dividing the total patient services operating expenses by the gross patient care collections for that same period. Patient financial services expenses must also include admitting and registration. Cash collected as percent of net revenue. This key performance indicator is also known as the net collection rate. It lets you know how much the actual cash you collected as a percentage of what was available to collect. It is the ratio of cash to net revenue. Denials as percentage of net revenue. Less than 2% of claims should be denied on the first submission, and that's what we should know about that. And last but not least, credit balances, days outstanding. Credit balances should be resolved timely and should be benchmarked at less than 1% of the days outstanding in the accounts receivable. And we're on a key concept slide. Key performance indicators or KPIs are set standards for accounts receivables or AR and provide a method for measuring the collection and control of AR. Days in AR is calculated based on the volume of the total accounts receivable on a specific date. AR day calculations can also be done for a specific payer to evaluate the collection, efficiency, and payment progress on third-party payers or self-pay patients. And completing of an analysis of AR aging and KPIs can help identify issues and areas for improvement. And we're on our last polling question of the day. What are KPIs? Just take a moment to answer that question. And it looks like it was pretty tight between the first and the second option, but the actual answer is B, key performance indicators which set standards for accounts receivables and provide a method of measuring the collection and control of AR. And that is the end of our presentation for today. So I'm going to stop my screen sharing, and we can open it up for any questions anyone may have. I don't see any questions on the chat.
Hey, Natasha, it's Christine Fontaine. I just wanted to thank you so much for doing such a great job today. It was very, really informative, and I know that the membership appreciates it. So wanted to thank you for taking the time.
My pleasure. Well, thank you for everyone for joining today and staying put through our presentation. Don't forget to join us next week at the same time for our third session. And we're going to be covering, we're going to start on section 2. So we hope to see you next week, and we hope that you have a good rest of your week.